Good afternoon. Welcome to UCSF Medical Grand Rounds. This is our 41st installment in our COVID series, which has been viewed around 2 million times online and by several tens of thousands of people live. I'm Bob Wachter. I'm chair of the Department of Medicine. Just by way of a preview, we will do one more COVID Grand Rounds in 2 weeks. And then normally we take a break from Grand Rounds over the summer, July and August, and we will plan to do that. We'll come back during that time if there are breaking topics, but it looks like things are reaching a stage where we may be able to take a little break. And then if so, we'll be back in September with our normal Grand Rounds, throwing in COVID topics as is appropriate. We'll have to see what George tells us, but life does seem to be returning back to normal here, at least in the US and the Bay Area. And with that, our conferences will begin to do that as well. The ground rules are here. You know them by now. Zoom in full screen. If you have questions, type them in the Q&A box. My colleague Quinny Cheng is monitoring those, and we'll try to get to as many as we can. And closed caption is available to you at the bottom of the screen. And as I said, we will post this, as always, on YouTube tonight, probably about 7 o'clock. We'll begin with another update on the state of the pandemic from my friend George Rutherford. George, as you know by now, is professor in the Department of Epidemiology and Biostatistics, directs UCSF's Prevention and Public Health Group, and has given about 6 billion presentations on the state of COVID to all sorts of audiences over the past 15 months or so. After George is done, we'll have a few questions, and then we'll spend the bulk of our time discussing efforts to vaccinate more people. The vaccine rollout has been an amazing success and largely responsible, I believe, for the numbers that George will show us. But it's become more challenging as time has gone on, and we'll hear from 3 experts talking about 3 different perspectives about encouraging vaccination. I will introduce them to you after George's presentation. So let me turn it over to George Rutherford.
Thanks very much, Dr. Wachter. It's a real pleasure to be here. If I did 6 billion, that's like, I want to be up to 9 billion, given one to every man, woman, and child on earth. That's what it feels like about now. Yeah. Nice round number. Good. So let's start up. Worldwide, as you can see, cases are coming down again and mortality is coming down. We're clearly through this 3rd wave of the epidemic, which only touched the United States very lightly, in the upper Midwest predominantly and along the eastern seaboard. India, the cases in India are thankfully falling as they are in Europe, not so much in the Americas. There have been 3.5 million new cases last week, which is down 15%, and unfortunately 78,000 additional deaths, but although that is also down 7%. I put up this so you could track it. So here's India. This is actual number of cases, not per 100,000. So you can see this big drop off. US is remaining low and Brazil is perked along. The other countries that are having lots of cases are Argentina and Colombia, all part of this sort of South American outbreak, which is what's accounting for a lot of the cases in the Americas right now. And then other countries, the next of the top 12 are Iran, the Russian Federation, France, Turkey, Malaysia, which we haven't really talked about much before, Nepal, and Chile, which is a really interesting case because they have high vaccination coverage, although it's been predominantly with a Sinovac vaccine. Here in the United States, cases are coming down, continuing to come down. They've dropped 46% over the last 14 days. We're still, averaging 16,000 cases a day, which is not nothing. Hospitalizations are down and mortality is also thankfully down. We're almost to 600,000 deaths. California, cases have fallen by another 1/3 over the last 2 weeks. And we're under 1,000 cases a day now. And the hospitalizations have continued to fall, as have deaths. And there were been 39 deaths. A couple of weeks ago, there were 0 deaths in Los Angeles for a couple of days in a row. Here in the US, across the US, California leads the country with the fewest number of cases per 100,000. We are actually tied with with somebody like Palau or with some of the Pacific Island groups. If you look at where cases are still occurring, there are outbreaks in Washington. The Oregon one has seemed to have abated a little bit. Wyoming and Colorado, West Virginia, an interesting story we'll get to, and Florida. The upper Midwest, somewhat still. Pennsylvania still impacted. Maine still impacted. But you're seeing kind of this, a real kind of diffuse pattern. And almost everywhere except for the U.S. Virgin Islands have had falling numbers of cases over the last 14 days, some, except for Arizona, some at -2% in Wyoming, less than others, where you can see Florida's had a big drop, as has Colorado. Statewide, the RE, the effective reproductive number, is 0.76. It's been under 1 for quite a while. We have 0.8% test positivity prevalence. Hospitalizations are down 24% from 2 weeks ago, and overall ICU capacity is at an all-time high since this has started. This is a new graph that came out, interestingly, in the San Jose Mercury News, which took data from the state and tried to create a map of what the background levels of immunity were given both vaccination as well as a prior infection. And they thought that the highest prevalence of immunity was in the 4 southern most counties: Orange, Riverside, Imperial, and San Diego at 75%, 76%. And then in the valley, all the way from Kern up to San Joaquin at 70%, Los Angeles at 68%, the coastal and Bay Area also in the 60s, but in Sacramento. But the other thing, the whole tier of Northern California at 48.8% bespeaks a larger problem with under vaccination in this region. Currently, we have vaccinated, we've administered 37 million doses of vaccine in California. It's down to about 110,000 doses per day on average for the last 7 days. There's a real steep drop off here because there are delays in reporting. Almost 55% of Californians have received 1 or more doses, and 44% have been fully vaccinated in San Francisco. 71.2% of all eligibles have received one dose or more, and 60.3% are fully vaccinated. If you look at the top 10 counties in California by either who's gotten a single dose or who's been fully vaccinated, every county is a Bay Area county. I'm using it loosely. We're including Santa Cruz in that, with the exception of tiny Alpine County up in the Sierra. So we've done a really good job in the Bay Area of getting people vaccinated. Interestingly, J&J vaccine still hasn't caught on. There are big surpluses of J&J vaccine, which may well, unfortunately, end up outdating before it can be used. One of the things that's become apparent is that there's an urban-rural divide in vaccination coverage in California. Remember, I showed you this northern tier of states as having sort of high or low levels of immunity to the virus. If you look across counties, Lassen, Tehama, Kings is down here, kind of in the south, sort of the southern San Joaquin, Modoc, Yuba, Del Norte, Trinity, Shasta, Kern down here in the south, and Tulare down here in the south. These are the states with the lowest levels of vaccination. And in Lassen, it's 19.5% of people are fully vaccinated. In Tehama's not a tiny county. It's a reasonable population. 23% of people have been fully vaccinated. And this is these remain problems trying to move vaccine here. And I think that today's topic about vaccine incentives is especially important to pay attention to. Variants continue to grow nationally, with the B117, the UK variant, now being the predominant lineage at around almost 70%. P1, the Brazilian variant, has remained relatively low. The California variants have been, that's like about 2% overall, the 1429 and the 1427. And then the Indian variants are also at relatively low levels, 1.3 plus. These are below 1%. So, so this is a story of the B.1.1.7 variant kind of sweeping in the country and taking over the bulk of new cases. Now, confusingly, the WHO has decided that saying things like the UK variant and the Indian variant are overly labeling, and so we're going to change the names. So the Alpha variant, aka B.1.1.7, or the UK variant in California, has accounted for overall 55% of sequenced genomes that have been reported to CDC. California has a slightly different surveillance system. I'll show you in a second. The Brazilian, now called Gamma, is 10%. The South African, now called Beta, is 1.1. And the California, the West Coast variants, now called Epsilon, are 9.3. You may ask, for those of you who remember your Greek alphabets, what happened to Delta? Delta are the Indian variants, of which there are very few in California. If you look over time in California, you can see this kind of rise and fall of the California variants. Now I've now forgotten what they're called, Epsilon variants. But this rise of the UK, the Alpha B.1.1.7 variant, and you're also starting to see some of these other lineages emerge, in particularly the Brazilian lineage of the P1, P2, which is Beta, I guess. No, maybe it's Gamma. I don't remember. Sorry. That's the problem with these non-specific terms. In terms of what's going on, in terms of what's going on about vaccine acceptance, we remain at a core of about 20% of people who will only get vaccinated if required, or definitely won't get vaccinated. But we've moved on the proportion of people who are fully vaccinated. And this becomes important if you're a beer liver, as I'll explain later. We're up to 62%, and we're hoping to get to 70% by the 4th of July. Now, with regard to incentives, which I realize is the theme for today, without trying to tip everybody else's hands, I just wanted to point out Californians has 10 prizes of $1.5 million each for people who receive a first dose between now, this was last week, and June 15th. There are 30 awards of $50,000 each for people who've already received one dose, which will be awarded tomorrow and then 2 weeks from tomorrow. Everybody who begins and finishes their vaccination series will receive a $50 gift certificate or $50 grocery certificate, and this is a fairly weighty cost, but it's less than the cost of having another outbreak for sure. There are all these other incentive programs that I love. Lodi gives you a $25 credit on a utility bill. Santa Clara gives you $10 Starbucks and Chipotle cards, but also has tours of the 49ers locker room. I love that one. Krispy Kreme will give you a donut if you get vaccinated. And then the new one that just came out today that I hadn't caught before is that West Virginia is having giving out guns, trucks, and lifetime hunting and fishing licenses. You can see what a different country this is. And now down to the bottom line, Anheuser-Busch said that it'll give away free beer if the U.S. gets to 70% of adults vaccinated by the 4th of July. So that's if you didn't have an inducement before, there's your inducement. And now finally, I just wanted to note that for those from the ridiculous to the sublime, this is a really fascinating report that was chaired by Neil Poe at the San Francisco General, the Zuckerberg San Francisco General, from the National Academy on Social Insurance. And this is trying to help Social Security and Medicare, SSDI, other kinds of federal income support programs understand what the future of COVID will hold. And there are a lot of very interesting people on this committee, and I think it's a very thoughtful piece of work. I single out Diane Havler, especially, who was a huge contributor. I was on it too, but I kind of just was along for the ride. But this is a really cool report. And then finally, I just wanted to thank someone who's been working with me and fielding a lot of these slides and pulling the literature for the whole year, Sarah Coven, who will be actually starting college here in the later summer. She did a gap year between high school in college and now knows more about COVID than anybody else in the world. So I will stop right there. Thank you all very much, and happy to answer questions, Bob.
Great. Thank you, George. Time for maybe a couple of quick ones. I want to make sure we have time for the other portion. A couple of weeks ago, CDC changed their guidelines. A lot of criticisms, including from people like me, too fast. What have we learned about how it's worked, and were they right?
Actually, this is one of the things I didn't show you. After they changed their guidelines, vaccination rates have gone up nationally. It's good. It's, who knows whether it's cause and effect, but it's at least temporally consistent with the vaccination rates, with the masking rules changing, and people starting to see additional benefits to getting vaccinated.
So that seemed to be their bet. They thought it might induce people to be vaccinated, and that would outweigh more cases. And it seems like they may be winning the bet.
Yeah, and they're probably not going to be giving out guns and liquor.
Probably not.
Cigarettes. Probably not.
The Delta variant, or the Indian variant, appears to be spreading very rapidly in the UK.
Yeah.
First of all, why is that when they have so few cases? You would think, and we were told that part of the reason you want so few cases is you're not going to grow the variants quite as much. So why is that happening, and what are they seeing in terms of its impact on cases?
I mean, it's not huge growth. It's, hundreds of cases. It's not tens of thousands of cases. Basically everybody in Britain has had a single dose of AstraZeneca vaccine. And you're seeing the limits of a single dose. I know what you espouse, Bob, of a single dose strategy. And I think that's the issue. They're going to have to kind of plow through and get everybody a second dose. Yeah,
they're actually almost up to the same rate as we are with second doses. So I think they caught up. Had this happened 2 months ago, that would have been a big problem for them. You mentioned the P1, P2, or I forget the letter 2 as well. The Brazilian variant is now becoming, whatever, is becoming more prevalent here. There was a lot of worry about its vaccine resistance early on. Are we not seeing that?
We're just not seeing it to the extent that we actually can track individual cases. We're just not seeing it. If you look at the state's surveillance data, which is a much bigger data set than what CDC is showing, it's a few percent, but doesn't seem to be growing. It's really fluctuating around.
Okay. And last one, you mentioned, I think, a really good point, that you sort of, that rate of immunity is sort of some combo of vaccination and prior infection.
Right.
Now that we're over a year into prior infections, does prior infection last over a year in terms of its protection?
Probably. It's hard to say. And, if Monica were here, she'd talk about T cells and T memory cells and stuff, and which is true. But we do see breakthroughs of people. We see reinfections in people who've been infected once, which happens with other infectious diseases. Immunity is not perfect, but I think it pretty well holds. But I mean, the larger point is that you can't make that assumption, and you don't get as high level of antibodies, for instance, following naturally acquired infection, as opposed to vaccine acquired infection. And so the recommendation is to get fully vaccinated, even if you have been sick. Now, some of the European countries will say 1 dose is adequate, and I think we might come around on that eventually. But for right now, the recommendation is to get fully vaccinated.
Great. Thank you, George. Appreciate it. Let's move on to the next segment. So I think George set it up really well. We're now going to talk about efforts to vaccinate more people. The early part of the vaccine rollout was abysmal in December and January. It got really, really good beginning in late January and extending February, March, April. And now we've hit a little bit of a different phase where it's more of the ground game, harder to get people vaccinated, which raises all sorts of inevitable questions about how do you do that? Do you require it? Do you incentivize it? George went through a lot of the incentives. My favorite is you get to spin around Talladega racetrack if you get vaccinated, and I guess that's in Florida. And also, what about vaccinations in underserved populations? How much of that relates? Do we need to incentivize or require it? Or is this still issues of access and education? And so we have 3 terrific speakers to think through all of the issues around getting more people vaccinated. We're going to start with David Studdert, who's professor of medicine and law at Stanford. David is a leading expert at the intersection between law and medicine. You may remember David was here maybe about 6 months ago talking about the idea of vaccine passports or vaccine authentication. Before it was really a thing, it was just my sense it was going to become a thing, which turned out to be right. So he's going to talk to us today about what we've come to learn over the last 6 months or so about vaccine requirements, vaccine passports, authentication, and with a particular focus on the legal and ethical aspects of it. Then we will welcome back Kevin Volpe. Kevin hasn't spoken to us about COVID before, but he gave grand rounds, I think, a couple of years ago. Kevin is the founding director of the Center for Health Incentives and Behavioral Economics at Penn. He's also the founder's president's distinguished professor of medicine and medical ethics and policy at the Perelman School of Medicine and also at the Wharton School. Really, probably the leading expert in the world on behavioral economics as it pertains to healthcare, and had an important article in last week's New England Journal about this topic. And then our final speaker will be Karina Marquez, who's Assistant Professor of Medicine, Associate Director of Education in the Division of HIV, AIDS, and Global Health at Zuckerberg San Francisco General. She's also Associate Director for Equity in our Center for AIDS Research. She's had a leading role in the community-facing work that we've done, particularly focused on the mission and the Latinx population. Work that in the beginning was really more about testing and then pivoted over the last 6 months to being more about vaccination. They've had some great successes there. So the format here will be a short talk by each of the speakers and then a panel discussion with all three of them at the end. So let me turn it over first to David Studdert.
Thank you, Bob. Great to be with you again. I'm going to share some slides here. I hope you can see those okay.
Yeah.
And hear me clearly. Yeah, I do have a fond but somewhat distant memory of being with you a while ago. So when I looked this morning and figured out it was actually 6 months ago, that was a little shocking. It seemed much longer than that. But if we count time in terms of the number of twists and turns in public health policy, then I think I'm vindicated. So 6 months ago, the Moderna and Pfizer vaccines had just been approved and their rollout was just beginning. Bob, I remember you were on tenterhooks waiting for the call. And there was this sense of expectation that that rollout, because these vaccines are so astonishingly effective, would begin to restore freedoms in the community. And that would happen somewhat slowly and fairly unevenly. Like so much else in the pandemic, when there's a rare moment to kind of reflect on what we thought then and what actually happened, the answer is it kind of happened that way, but not exactly as anyone expected. One thing that was fairly clear from the outset is that there wouldn't be a government mandate. Childhood vaccine laws aside, there really isn't much precedent in US public health policy for rules that require people to take vaccines. The law actually provides the government with quite a lot of leeway to do that if it chose to do so in an emergency situation, but vaccine mandates are very rare in the modern era. And most experts are opposed to it, or at least quite skeptical about vaccine mandates as a move. One central concern here is that they just don't work very well. Demanding that people get vaccinated may backfire and cement rather than break through the reasons they have for hesitancy. So voluntary programs are generally preferred, and that's the course that the COVID-19 vaccine programs have taken. But voluntary doesn't mean passive. These programs can improve uptake if they're buttressed by efforts to increase access, to reduce mistrust, and to use some of the incentives that Kevin's going to talk to you about in a few minutes. So I raise all of this to get to a distinction that is really important, but I think widely misstated at the moment in public discussion around COVID-19 vaccines. It's just misleading and wrong to label any policy effort to boost vaccine uptake as a mandate or some kind of compulsory vaccination. A true mandate comes from the government and involves legally enforceable penalties, or the conditioning of access to essential things like the ability to go to work or to school on proof of vaccination, again, coming from the government. If a private concert hall or an airline decides that they'll only open their doors to people who can show proof of vaccination, not a mandate. Similarly, incentive programs usually don't amount to anything approaching mandatory vaccination. So the point here is that loose language and terms like mandatory and compulsory are unhelpful and quite distracting, but surprisingly common across the media at the moment. I mentioned that almost nothing kind of plays out in this pandemic the way we think it's going to. So we commentators really do prognosticate at our own risk. But Mark Hall and I have written several research articles about vaccine certification or passport programs. And we've tried to sort of opine on both their legal and ethical aspects, and also just think about how important a policy tool these are likely to become. Vaccine passports, of course, are forms of certification that attest to a person's vaccination status. Think of those little CDC cards with stamps of your dose numbers and dates. There's been a great deal of speculation, as most on this call know, that as vaccines became more widely available, these forms of proof would be used to regulate access to everything from sporting events to public transportation and to air travel. So how did we do in kind of reading the tea leaves here? Well, way back in March, we thought that the federal and state governments were highly unlikely to take a lead in pushing or adopting such programs, and that has largely proven true. There are a few exceptions, like New York's Excelsior program. New Yorkers can apply for a little QR code for their phone. The state issues that, and it verifies that the bearer has been vaccinated. Some establishments in New York, like sports and concert venues, are using it to restrict access. Also, a few places, including Santa Clara County, have issued public health orders requiring employers to ask employees to attest to their vaccination status. Those who say they've been vaccinated may return to work without the need for certain other requirements, testing programs, masking, and so on. Those who indicate they're not vaccinated or refuse to attest must submit to a testing regime and some other rules. So there are little spots of activity by the government, but those are mostly exceptions in terms of government action, very little strong government action in the passport area. Although not leaders of the passport programs, we didn't think the government would step in to stop them, to stop private businesses from adopting these programs. And that's largely proven true too, although 4 states at last count, Georgia, Alabama, Arizona, and Florida, have introduced laws banning any form of vaccine certification. And more state legislatures are considering these types of bans. And as you might imagine, they are breaking fairly strongly along political lines. We forecast that the private sector would lead the way with passport programs. That's proven true to a limited extent. 400 plus colleges have indicated that they'll welcome back students and faculty to campus in the fall if they're vaccinated. And some entertainment venues and employers are insisting on proof of vaccination. But I have to say, this was a bit of a whiff for us. You know, in the big picture, implementation of passport programs has been pretty modest. The airline and travel industry has not plunged in, as many expected, nor have the vast majority of employers. Even in New York, where the groundwork was sort of beautifully laid for this with the Excelsior pass system, most private businesses have not paid attention to them. And only about 10% of vaccinated New Yorkers have applied for the Excelsior passes. So this for me has been the most surprising twist. We're currently in a world of limited interest, I think, in certification, and moves like the CDC's, Bob, that you mentioned a few moments ago, relaxing the marks guidance for the vaccinated, but not tethering that to any system of verification, really draws attention away from certification policies. I don't necessarily think that's a bad thing, but in light of expectations about how important this would become, it is kind of surprising. So I just want to end by sort of posing the question, you know, what happened here? I've noticed really 4 developments in this area. One I already mentioned, and that's that there's this blurring of any version of certification with this concept of mandates. And that seems to scare the private sector and the government away from the idea. Second, there is sort of a cloud of legal uncertainty that's settled over these proposals, that private or public actors, you know, can't or aren't allowed to require information from individuals about their vaccination. HIPAA doesn't permit this. So long as the vaccines have emergency use status, then federal law prohibits this. These are very common statements in the media, and they're mostly false. Nonetheless, they create this perception of a legal thicket that seems to chill interest. Third, we've heard stories, including out of New York, that there's a backlash by a very vocal group when these kinds of programs are introduced. And finally, and maybe most importantly, I'm starting to get a sense that the constituency for these kinds of policies just isn't there. Those who are unvaccinated obviously aren't going to be the constituency. The vaccinated could be, but thanks to the tremendous effectiveness of vaccines, it may well be the case that many feel safe enough, even if they find themselves shopping, cheering, or dining alongside people who are not vaccinated. So maybe there's a push coming later than we expected. We're not sure from where. Maybe this will come at a later stage of vaccine rollouts. And possibly future outbreaks and variants could change the dynamic. A lot may depend on where vaccine coverage levels settle when they finally do. In other words, what is the size of the long-term risk that communities will face? So let me stop there and hand off.
Great, David. Thank you. That was just perfect and really updated us. And yeah, I had the same prediction you did. It just felt like this was going to be a big thing, and it's become a small to medium thing. And I think your explanation is compelling. We will get to more of it in the Q&A section. Let me turn it over to Kevin. I think you've been pretty well teed up as we now talk about incentives.
Yeah, well, thank you for the really great talks by George and David, and I'll try to build from there. Let me just bring up these slides. But here's where we are. I think we're all familiar with what's happening, and as a result, many states are offering financial incentives to get vaccinated. George talked a bit about Vax for the Win, but there's about 5 other states now that are offering multiple $1 million plus lottery prizes. So I want to highlight this is all unprecedented. It used to be a big deal for an incentive for a health behavior to be $1,500. So to have prizes of $50,000, $100,000, multiple $1 million prizes, this is brand new. And we wrote a paper about this last week. I wrote it with my colleague Carolyn Canusio, because I have some concerns that this may not be the best path for us as a country to be going on. There are a number of good reasons to consider incentives. So a classic reason that economists give for government intervention in the form of subsidies is when there's what's called a positive externality. So my actions affect other people in desirable ways. And in essence, what this means is, for example, with a vaccine, is that people aren't adequately considering the benefit to others in my decisions. My getting vaccinated helps you, but in a free market, since I'm not weighing the benefit to others, there's going to be too few people getting vaccinated, and that's a good rationale for a subsidy. If you think about the flip side of that, it's the classic example is pollution of a negative externality, where we don't just let people spew pollution into the air. We fine or charge factories for doing that so that they have to internalize that cost. So that's the two sides of that coin. Another good reason for considering incentives is there are costs for people who have to take time off from work, arrange childcare to get the vaccine. This is particularly important for lower income communities where vaccination rates might be lower. A third is the potential for cost savings. There's lots of examples where incentives are being used to try to encourage healthy behaviors. This is obviously a big one. The best estimates I've seen is that the total estimated cost of COVID to the US is $16 trillion. So when we talk about multiple $1 million incentives, that sounds like a lot of money, but it's actually not in the context of what the consequences of COVID economically have been for the country. And then fourth, there's a pretty good track record of incentives being used in other contexts in increasing rates of healthy behavior. Good reasons to think incentives for COVID vaccination could be quite effective. So here's some potential concerns. One is there is potentially, and I saw this was raised in the Q&A, a major equity issue relative to those who are already vaccinated. I got vaccinated on my own. It would be very unfair in my eyes for other people now to get paid to get vaccinated. And this is potentially a major issue depending on how the incentive programs are designed and who's eligible. A second major concern is that if booster shots are needed, and if they're needed repeatedly, are we creating a monster? Is everyone going to expect to get incentives? Are we, in essence, creating a new form of vaccine hesitancy? A third potential issue, which I'm less worried about now, is that it could send the message that vaccines are undesirable or unsafe. If these are so great, why is the government paying me to do this? I think that would have been a major issue if incentives had been introduced at the beginning of vaccines being made available. It's less likely to be a major issue now that 168 million Americans have been vaccinated. I think there are some better alternatives than wide-scale financial incentives to get vaccinated. One, and this gets back to some of the issues that David raised, are while I don't think a widespread governmental mandate is possible, there are more selective mandates that could be considered. So healthcare organizations, for example, could choose to mandate that their workers be vaccinated as a condition for going to work. I'm very proud to say that my employer, Penn Medicine, decided to do this, made an announcement about 2 weeks ago that all of our employees are required to get the COVID vaccine. There are, of course, religious and medical exemptions. Other settings where this might be thought of as employer settings. A private employer could choose to do this. Those where there are particularly high rates of COVID transmission, like meatpacking plants, might think about it. There are a number of, as David mentioned, a number of schools, colleges and universities that have issued requirements that if you want to be a student here in the fall, you need to get vaccinated. Then there's a big category of conditional incentives. And as David said, it's interesting that the whole vaccine passport hasn't really taken off as we might have thought. There's a number of examples of where people are getting access to desired services that are not essential by dint of being vaccinated. So for example, if you wanted to go to the NFL draft in Cleveland, Ohio, the European Union has announced if you're a vaccinated American, you're welcome to travel there this summer. There's some concerts, some restaurants that have said if you're vaccinated, you're welcome. Or, for example, Governor Inslee in Washington State said we're opening extra sections of the Mariners Stadium for people who are vaccinated. I list college and universities here again because there's some conditional versions of the blanket mandate that are an interesting flavor. So, for example, some colleges and universities have said if you want to live on campus, you have and fully participate, you need to be vaccinated. And that could be thought of as a conditional incentive as opposed to a mandate. A third alternative would be for health insurance premiums to be raised on unvaccinated people. So in other words, having them internalize the external costs they would impose by on average having higher healthcare costs in expectation than other people. But given the resistance to mandates and conditional incentives that we're seeing around the country, we may need to consider alternatives. And I think if you're using a financial incentive, there are a lot of good reasons to consider using lotteries. People tend to overestimate small probabilities near zero. Large magnitude rewards obviously get people's attention. There's the ability, depending on how these are designed, to engender what's called anticipated regret. I can anticipate I would actually be very disappointed if my number was drawn and I didn't get the $1 million because I hadn't been vaccinated. Although that said, there's a lot of states which are not designing this in such a way where that could actually happen. And I can talk more about that later. There's also the entertainment value. I think there's going to be a lot of really interesting stories in the papers around the country about, this person won $1 million, this young person won a college scholarship. A lot of interesting human interest stories, which will create publicity for the vaccine. I heard a presentation yesterday from one of the people who's running the Ohio vaccine, and they said that they think the publicity from their $5 million prizes and the 5 college scholarships being run over this 5-week period has already been worth $24 million in free advertising money about vaccine awareness. Another, I think, desirable approach, which has been used in many states, but not all, is fairness to those who are already vaccinated, who are fully eligible for these lottery prizes whenever it doesn't matter if you got vaccinated in March or in May. So that I think is useful. That is not true for states that are now offering a gift card for getting vaccinated today. And I think this lottery type approach is probably going to be more effective than offering each person a set amount of money. Partly it depends on how much money that is, but the average cost per incremental person vaccinated in Ohio the first couple of weeks of their vaccine campaign was probably about $40. And I'm guessing that will be more effective than what's happening in some other states. I do want to highlight lots of other states are now offering $1 million plus lottery rewards. So again, unprecedented territory here. Nobody knows what the effect will be, but we will learn pretty quickly. So let me stop there and happy to take any questions.
Perfect. Thank you, Kevin. Really incredibly interesting stuff. Let's turn to Karina, and then we'll get back to both of you for all three of you for questions at the end. So Karina's going to address some of the issues around vaccinating underserved populations and minority populations and what we've learned from some of our experience in doing that, I think, quite successfully.
So I'm presenting on behalf of the Unidos en Salud collaboration, and I'll be sharing data on the design, the implementation, and the evaluation of a community-based strategy to facilitate COVID-19 vaccine uptake among Latinx persons in San Francisco. And while this is one strategy, one intervention, I think there's a lot of generalizable concepts that can be used to address vaccine equity and the disparities we're seeing. So first to start, Unidos en Salud, who are we? Everything we do is rooted in partnership. So we are an academic community and city and public health partnership. We are focused on optimizing and innovating community-based COVID-19 test and respond and now vaccination models, and working towards generating data to drive solutions to address COVID-19 inequities. We partnered early on in April of 2020 with the San Francisco Latino Task Force, which is an amazing coalition of over 30 Latino-focused community-based organizations, community leaders, and community activists. And I think before getting into the vaccine model, I think it's important to share that we have been doing testing and providing response services in the community since April. And many of the lessons and things we learned about testing we've applied to vaccination. Additionally, in January, we were able to survey many of the people who came to test at our vaccine site. So among 4,133 people seeking testing, we noted what is seen, I think, widespread in other surveys similar to this, that vaccine confidence was high among Latinx persons that were testing at our site. So when we asked in January, when you're eligible, we found that 86% of people said, I would definitely get it, probably get it. And that 72% of people said, I want to get it now as soon as possible. So we knew that there was, at least in this population, a high amount of confidence, and that we needed to focus very much on access and making sure that when it's available, that people can access it. Of the 14% that were deliberating or not there yet, we also were very interested in addressing their concerns, and trust in vaccine efficacy, safety, and the healthcare system itself were top concerns. So let me tell you a little bit about the strategy. This is a multi-component community-based strategy. This is a picture of the site we opened on February 1st. And we had 3 pillars: motivate, vaccinate, and activate, which I will share each piece of these components next. So motivate. Community mobilization and demand generation was a key focus. And we did this in a variety of ways. One size does not fit all. We did direct recruitment from different community-based organization networks. CBOs could refer their clients directly. We did face-to-face outreach, in-person registration, informational events, cafecitos, where we had a doctor in a white coat on the corner of 24th and Cap, that you could share pan dulce and coffee with them and talk about vaccines and your concerns. Spanish language radio, referrals from our test site, and education at the test site were also there. Vaccinate. So a community-based, low-barrier, client-centered vaccination site was obviously a key component. We really focused on convenience. The site was located at a transport and cultural hub at 24th and Cap. We had low-barrier scheduling. You could register on site. And as supply increased, you could walk up and drop in. You didn't need documents to get a vaccine. You could self-attest to eligibility. We had Sunday appointments if you worked during the week. We had Spanish-speaking staff, of whom most were local community members. And then thirdly, the activate component. We knew that trusted messengers were going to be a key component. And so in addition to trusted community leaders and members doing education and outreach, we wanted to leverage the social networks of people getting vaccinated to increase uptake. And so we had two interventions, the community health team, this is the picture of them here. After in the post-vaccine area, this team would talk to you about vaccine-related questions, side effects, and then really directly encourage people getting vaccinated to reach out and become a vaccine ambassador to their unvaccinated family and friends and peers, and provide additional information, QR codes to sign up, things to make it easy. And then lastly, we wanted to make this welcoming language concordant site that the site itself could instill trust. So what about the evaluation? How well did it work? So we evaluated this multi-component intervention with the REAIM implementation science framework. We had two data sources, programmatic data, and then a survey that we administered in the post-vaccine waiting area in May. And then our outcome measures, we have, I'll just present the R and the E of the REAIM framework, but reach and effectiveness. And in effectiveness, we were looking at the proportion of people who reported being vaccinated sooner and those who recommended vaccination to friends. So CAME, this is a little bit about reach. So in this top bar, you can see the race, the ethnicity of clients vaccinated at our site. 81% were persons of color, 71% were Latinx, and you can compare it to the race ethnicity of residents in the Mission District, and you can see that it's a much higher proportion. The majority had a household income of less than $50,000, 51% were first generation immigrants, and 46% did not had a primary care doctor. The reach extended beyond the mission. This is a heat map of who we vaccinated, and you can see we also were able to reach the heavily hit areas in the Southeast sector. Okay, effectiveness. What did we find? So certainly people were vaccinated sooner. 58% said they thought they would have received the vaccine later had the site not existed. People were vaccine ambassadors. 40% in May knew at least one person who had not been vaccinated, and 90% reached out to one or more. And then this pie chart shows you how many people that they reached out to, they knew of getting vaccinated. You can see quite high numbers. What is the secret sauce? Why did people come? So you can see in the green table how they heard about the site, and in the blue side, what made them choose the site. And I would say, to summarize it, trust and convenience are the key factors. Most heard about it from a trusted messenger. 36% were told about it, the site, from a friend or family. And people chose it because of convenience. It's easy. It's easy scheduling. It's in their neighborhood. They pass by. It may be a trusted location. And then lastly, the site experience was important. 89% said they were more likely to receive vaccination, recommend vaccination to their friends after their experience at our site. People came back. The people getting their first dose with us, 98% came back for their second dose. And people, what they liked most were the friendly staff, site efficiency, and staff being bilingual, amongst other things. And you can see the things they chose. So just to conclude, this intervention did reach the intended population. We had high uptake amongst Latinx residents, and vaccinated individuals served as ambassadors. It's not a one-size-fits-all. We need multiple strategies, and so demand generation through trusted networks, messengers networks, adaptable mobilization strategies, and convenience are in our intervention underlie, I think, a lot of our success. And then, of course, cannot underemphasize the importance of community, academic, public health partnerships to promoting equity. And many people were involved in this. This takes a community to end a pandemic, and just highlighting and acknowledging the many collaborators in this project.
Great. Thank you, Karina. Let's bring on everybody. So if Dave and Kevin can come back as well, that would be terrific. And Great. Hopefully everybody can see just you. I have a sort of funky screen. Thank you. And Karina, I had a chance to visit the site about a month ago, and it's really inspiring. It's really, really, really impressive. David, you mentioned the Excelsior Pass, but didn't sort of dwell on the lack of a trustworthy source and the fact that I can go online and buy a CDC card for $6 or something like that. How much was sort of a chicken egg problem that there was no source, if a restaurant or a workplace said to me, oh, we're checking vaccine passports, and I, as a vaccinated person, oh, great, that makes me feel more comfortable. The fact that I'm really not comfortable that everybody's CDC card is legit sort of screws up the whole thing from the get-go. So how much is that a root cause that we never had a trustworthy source? Maybe New York proves that was not the answer.
Yeah, so the fraud and the counterfeiting has been a question from the beginning with these programs, and there has been some commentary on this in New York. One journalist was able to download a QR pass from social media within, I think, 6 minutes of trying to do that. But I think it's kind of wildly overstated. We have these questions that arise for all sorts of identification, and somehow manage to stumble through and still sell fire insurance and do other things. The other thing to point out is that the program is not being strictly implemented. Most establishments that are using it are reportedly just asking to see the QR code on someone's phone as they walk in. They are not actually scanning it and linking to the local immunization databases. So there is a sort of a trust but don't completely verify flavor to the entire program that I think makes this question of sort of counterfeiting maybe less important than the program itself.
Okay, great. Kevin, you said this is unprecedented, but I imagine there are other analogies of societies trying to get people to do things. And you mentioned that lotteries sometimes work better than the same amount of money doled out in small equal boluses to everybody. So what are the lessons if you were sort of a policymaker and you said, we're thinking about a lottery to try to incent people from other things that we have tried to incent that are like this. I'm trying to think of an analogy, but maybe you have one in mind. What do you think the lessons are?
I think there are a few clear lessons. The first is, if you're going to provide some sort of incentive, make sure you're giving away something people will actually value. And that could be I heard about one state that was doing apparently low number license plates are really coveted and hard to get. You can imagine cash, of course, being the universal currency. I think that the challenge with beer or donuts or other giveaways like baseball tickets is not everyone likes beer or donuts or baseball. So you don't want to set up an incentive program that's non-motivating because what you're offering isn't seen as valuable. And I think that leads to thinking cash is the universal currency. I think it's really important to make sure that how the system works is transparent, easy to understand. People don't have to wait months to get the proverbial check in the mail. And I think that you want to make sure that people see it as equitable. I think that's a really good reason for having a system where anyone who's been vaccinated, whenever it might have been, is eligible, as opposed to just rewarding people who didn't get vaccinated yet. I think that rubs a lot of people the wrong way. We have as Americans, an inherent sense of fairness, and I think that unfortunately might lead to a bit of a backlash against these programs. And as I mentioned, another concern is that the next round, if there is a next round, we've sort of set ourselves up for an even more challenging situation.
And what do we know from, I know a lot of your work sort of flows from the old Tversky Kahneman stuff about whether positive incentives or negative penalties work better. So you have a little bit of both here. Most of this, beer, donut, lottery, spin around Talladega is positive, but you also have, as David said, you can't get into a place if you don't have. So it's sort of a negative. You're privileged if you have it, and you're deprivileged if you don't. What do we know from the behavioral economics literature about which one of those works better?
Well, generally speaking, it's people always talk about how losses are more impactful than equivalent dollar gains. But this is a context where it would be very difficult to apply financial penalties in any meaningful sense of the word. I think the one context I can think of is really health insurance, where you could charge people in some settings, like self-insured employers, you could charge people more who, and David, please correct me if this isn't right, you could charge people more if they aren't vaccinated. But I think in most settings, what we're really looking for is positive inducements, the proverbial carrot, where we're trying to encourage people to do something they don't want to do, trying to amplify the message here by using sticks is unlikely to be successful, and there's really not a mechanism for enforceability that I could imagine working.
David, any comments on that?
No, I agree with Kevin. I think that's exactly right.
Yeah. Karina, the data you showed was pretty striking in terms of the population wanting vaccination. And we heard all of this talk about vaccine hesitancy in communities of color. Was that a myth? Are Latinx patients different than Black patients? Is it the Bay Area thing? And if you went to Latinx patients in other parts of the country, you'd see different numbers. What's the truth as we've learned it?
Yeah, I think there have been, since we did the January study, there have been also some other larger studies and surveys in Latinos and in Black patients. And I think what came out of it is a lot of it, the hesitancy, it's not all hesitancy, and that so much of it is access. And I think making sure that that we address those access barriers first is, in addition to the hesitancy barriers, is critical. And so I think we thought that the interest was going to be high, but it was nice to see those numbers and really focus on access. I think, our strategy is always sort of adapted to the current scenario. I think certainly in the beginning, we had much more demand than supply. And as supply is becoming less of an issue and vaccine rates are so high, we're really sort of really focusing interventions to people who are much more hesitant or still on the fence. And I think for us, a lot of the one-on-one conversations with trusted sources have been pretty instrumental, I think, in nudging people sort of along that continuum of hesitancy. So things have changed, and I think our strategy also has to change.
And any information about people sometimes obviously incorrectly grouped together, communities of color? Do we know anything different? Are Black communities different on this and acting differently on this than Latinx communities?
I think access is still a very important issue within the Black community, and I think focusing on that, is critical. And I think a lot of these lessons and sort of strategies that we've employed within the Latinx community, I think, can certainly be generalized to other underserved communities, and have been. I think we've seen many examples. I think Dr. Rhodes with Umoja Health has really, by sort of also employing similar kind of techniques, putting vaccine sites in local areas, churches, neighborhoods, having a kind of run by the community, co-designed, co-led, have really allowed and addressed a lot of access barriers in addition to trust barriers. And I think those strategies have really worked well in communities outside of San Francisco and in other underserved communities.
Great. I see we're running up on the hour. Can you guys stay for 5 more minutes, or Kevin's okay, David's okay, Karina's okay? Good. David, one of our watchers said, considering vaccinated versus unvaccinated employees in a workforce, do conditional incentives, if promulgated by the employer, create unequal benefits and raise potential EEOC issues?
Yeah, it's a great question. And thankfully, we have 2 guidances now from the EEOC that help us answer this question. So back in December, the EEOC issued a guidance. And again, last week, we received a guidance. And last week's guidance addressed the issue both of whether employers can insist on vaccination for their employees and whether employers can use incentives. And the answer to both questions is yes. Of course, it comes with some provisos. In order to not run afoul of the Civil Rights Act or the Americans with Disabilities Act, there has to be reasonable accommodations for people who really can't get vaccinated for a medical reason. And of course, the programs have to be implemented fairly. You can't apply them to one group differently than another group. But if you stay within those bounds, what the federal government is saying is that it does not see a problem with breach of discrimination or disability law.
Great. And I want to ask you one more question about your Santa Clara example. So it wasn't completely clear to me. Are they requiring that every business set up an enterprise where you are sort of privileging vaccinated people to come in, or they are allowing it and businesses can choose to do that or not do that?
They're requiring it. So I use it as an example of not exactly a mandate because it's being sort of mediated through the employers, but they are asking employers to have their employees attest to their vaccination status. And if you say that you're unvaccinated or you refuse to attest, you will be treated as if you are unvaccinated, and the county policies that apply to the unvaccinated in public settings and so on will apply to those employees. Again, reasonable accommodations will need to be made. This may be the difference between continuing to work through Zoom and coming into the office, or it may be the difference between an employer asking for weekly test results from folks who won't attest and not asking for the same for those who do. So it carries some implications. I don't think another county has gone quite as far as that, but as you know, Bob, we have a very active public health officer here, and they're really pushing the envelope on this one.
Yeah. Do you think that that's a short-term thing, and once case rates go down to a certain point, the political pressure to get rid of that is going to be such that will go away? Or do you think this is sort of it for the duration?
I suspect so. And I think, like the CDC's move, the way to interpret these policies is to see them as trying to incentivize vaccination. And if we can get vaccination to where we want it to be, I think the imperative for these kinds of intrusions will become less.
Yeah. Kevin, as you think about the future, you sort of hinted at this, but I guess I'm wondering about if this becomes a sort of fact of life, but more like the flu, but people have to get another booster every season, let's say every winter. Do you think now there will be an expectation of some sort of incentives, or have we created this monster that we're never going to be able to get out of? And maybe is there evidence from other incentive programs in the past about that when you're sort of past the short-term acute phase and now you need to figure out what we do for the long haul?
I've actually been debating that with some other behavioral economists, whether these types of incentive programs will crowd out intrinsic motivation so that next round fewer people will get vaccinated on their own, or will crowd in. And the story I've been mostly worried about crowding out, that more and more people will think, oh, if I just wait this time, I'll get an incentive, so I should wait. But the alternative view of that is that some of vaccine hesitancy relates to people being afraid, people worrying about side effects, people having maybe some misperceptions about the relative efficacy side effect profile of the vaccine. And maybe if more people get vaccinated, albeit because of an incentive, and it actually goes well, and many people they know also get vaccinated, it goes well, then maybe next time people will be less hesitant. That would be the hoped for version of the story, but I don't think we know. There's reasons to think that could be possible, but also lots of reasons to worry that we've created expectations that we will have to live with.
Yeah, let me let Karina have the last word. Sort of it didn't sound like you're offering incentives, maybe except for the cup of coffee with somebody to talk to you about. Depends how good the coffee is. Are you using incentives? Have you thought about using incentives? It sounds like most of it is education, convenience, and kind of peer ambassadorships. But what have you thought about incentives?
Yeah, we haven't formally evaluated incentives. We've done little things, with lotteries and other little strategies that we haven't been able to formally see the efficacy of. I think we are definitely thinking about it right now with the California program, how to message that to people who are coming to our site, to provide the information and how to do so. And so we will be, people are coming up asking about it. Others don't know about it, and we want to make sure they do know about it. So those are things we're actively trying, and I think are an important component. And as I mentioned, I think different strategies are needed for different people, and this may nudge some people, and so I think it's important. And just to close, I think when we're thinking, I've always liked the WHO working group on vaccine hesitancy, and they sort of identified the 3 C's of hesitancy. One being confidence, so ensuring trust in the vaccine and the efficacy. And so we've been doing that through a lot of the social networks and the outreach. Complacency, the people who are just like, I'm on the fence, COVID's not that bad, and maybe incentives and sort of a lot of convenience. These things can tip people over. And then convenience is the 3rd C, and things that we've addressed. So I think incentives in this era, certainly have a role, and we'd love to sort of kind of formally evaluate how they work in our communities. So.
Yeah, you can imagine what this conversation would have been like if these vaccines didn't work that well. I mean, it's actually interesting that we just got to the first mention that these vaccines are actually breathtakingly effective and remarkably safe. And it's a little surprising that we would need incentives, but I guess that is life. It's fascinating the way this has played out. Let me thank the 3 of you for a really interesting conversation and a really important conversation as we move to this next phase. Hopefully more people get vaccinated, and we will continue to do well with COVID as we've done over the last several months. So thank you all, and we will be back next week for a regular Medicine Grand Rounds, thanks to the production team who is up here. And then in 2 weeks, we will come back for what might be our last, at least regularly scheduled COVID Grand Rounds. We'll see how things go. So stay safe, get vaccinated. We'll talk to you soon.